is Bill Cox, and I'm the chairperson of the Haverhill Democratic City Committee. And the Haverhill Democratic City Committee currently has a headquarters at 310 Main Street next to Walgreens in Monument Square, where you can get information regarding the 3 ballot questions we're going to be discussing this evening. Volunteers are always welcome at our headquarters, so please feel free to stop on by. We're pleased to host tonight's ballot forum for the questions which will appear on the November 6th election ballot. Before we get to introductions, I'd like to thank HC Media for the use of this superb state-of-the-art studio. I also want to thank those Haverhill Democratic City Committee members who worked tirelessly to put this event together, including Linda Lankowski, Rosemary Young, Roz McKeon, Ron Peastree, Gene Sanders, and Cherie Bemelman. We have assembled 4 guest speakers who bring an outstanding breadth of knowledge to the issues facing voters of Massachusetts in this year's election. Each speaker will have 15 minutes to present their perspectives on the initiatives at hand, and then we will ask the audience attendees to follow up with their own questions or concerns. We have a microphone here in the front, and if you'd like to ask a question when we get to that segment, just step up to the microphone. Each ballot question summary will be read from the Information for Voters pamphlet sent to all state residents by the Secretary of State. So at this point, if you'll bear with me, because it is a little long, I'm going to read the summary for question 1. Question 1. These summaries, by the way, are prepared by the Attorney General of the Commonwealth. This proposed law would limit how many patients could be assigned to each registered nurse in Massachusetts hospitals and certain other healthcare facilities. The maximum number of patients per registered nurse would vary by type of unit and level of care as follows. In units with step-down intermediate care patients, 3 patients per nurse. In units with post-anesthesia care or operating room patients, 1 patient under anesthesia per nurse, 2 patients post-anesthesia per nurse. In the Emergency Services Department, 1 critical or intensive care patient per nurse, or 2 if the nurse has assessed each patient's condition as stable. 2 urgent non-stable patients per nurse, 3 urgent stable patients per nurse, or 5 non-urgent stable patients per nurse. In units with maternity patients, active labor patients, 1 patient per nurse. During birth and for up to 2 hours immediately postpartum, 1 mother per nurse and 1 baby per nurse. When the condition of the mother and the baby are determined to be stable, 1 mother and her baby or babies per nurse. Postpartum, 6 patients per nurse. Intermediate care or continuing care babies, 2 babies per nurse, and well babies, 6 babies per nurse. In units with pediatric, medical, surgical, telemetry, or observational outpatient treatment patients, or any other unit, 4 patients per nurse. And in units with psychiatric or rehabilitation patients, 5 patients per nurse. The proposed law would require a covered facility to comply with the patient assignment limits without reducing its level of nursing, service, maintenance, clerical, professional, or other staff. The proposed law would also require every covered facility to develop a written patient acuity tool for each unit to evaluate the condition of each patient. This tool would be used by nurses in deciding whether patient limits should be lower than the limits of the proposed law at any given time. The proposed law would not override any contract in effect on January 1st, 2019 that sets higher patient limits. The proposed law's limits would take effect after any such contract expire. The State Health Policy Commission would be required to promulgate rules to implement the proposed law. The Commission would conduct inspections to ensure compliance with the law, and any facility receiving written notice from the Commission of a complaint or violation would be required to submit a written compliance plan to the Commission. The Commission could report violations to the State Attorney General, who could file a suit to obtain a civil penalty of up to $25,000 per violation, as well as up to $25,000 for each day a violation continued after the Commission notified the covered facility of the violation. The Health Policy Commission would be required to establish a toll-free telephone number for complaints and a website where complaints, compliance plans, and violations would appear. The proposed law would prohibit discipline or retaliation against any employee for complying with the patient assignment limits of the law, and the proposed law would require every covered facility to post within each unit, patient room, and waiting area a notice explaining the patient limits and how to report violations. Each day of a facility's noncompliance with the posting requirement is punishable by a civil penalty of between $250 and $2,500. The proposed law's requirements would be suspended during a state or nationally declared public health emergency, and the proposed law states that if any of its parts were declared to be invalid, the other parts would stay in effect. The proposed law would take effect on January 1st, 2019. So if you've ever wondered what it's like to be a state legislator, now you have some idea, because this would be the bill that would be before you that you would be asked to vote on, and that's in fact what is happening on November 6th. You're being asked to vote on that. So first, we have two folks who have kindly given us their time this evening to come and talk about their different positions on this ballot question. And we have first, speaking for the yes vote, Mary Sue Howlett, who's the Associate Director, Division of Nursing, Massachusetts Nurses Association. Speaking on the no position would be Karen Moore, who's the Senior Vice President of Operations, the Chief Nursing Officer at Lawrence General Hospital. We're going to start with the yes position.
Thank you. Can I have my slides?
What's that?
My slides? Thank you. Thank you for this opportunity to talk about the Patient Safety Act. My name is Mary Sue Howlett, and I have been a registered nurse for more than 34 years. The Patient Safety Act, or Question 1, is an important issue that has implications for all residents of Massachusetts. Whether you're a member of the healthcare workforce or a patient who deserves the safest care we can provide. Many voters are surprised to hear that currently there is no limit to the number of patients assigned to a registered nurse at one time outside of the intensive care unit. Question 1 places a limit on the number of hospital patients that can be assigned to an RN. The limit varies based on the type of hospital unit and the complexity and severity of the patient's condition. And it includes exceptions for public health emergencies. It is not a rigid one-size-fits-all. If you're in the hospital, you're pretty sick. Patients are in the hospital because they require around-the-clock care from a registered nurse. Right now, the judgment of the nurse at the bedside is being ignored, and nurses are being forced to take care of too many patients at one time. Question 1 allows for early detection and prompt intervention by the nurse if a patient's condition deteriorates. That can't and doesn't happen if the nurse is assigned too many patients. Opponents of Question 1 will tell you that it takes away the professional judgment of the RN. In fact, the opposite is true. Registered nurses now assess their patients, and when they are assigned too many patients at one time, to be able to adequately care for each one, meeting the demands of the patient and the family, a call is placed to the supervisor or manager. In unionized facilities, RNs complete an objection and documentation of unsafe staffing form to document the conditions that exist at the time and the response from management. All too often, the response is, do the best you can. We cannot do the best we can if we have too many patients. Already this year, the Massachusetts Nurses Association has collected over 2,000 unsafe staffing forms from RNs working in Massachusetts Nurses Association represented hospitals. They are here before you. These forms are submitted to the administrator on site and brought to labor management meetings in an attempt to identify situations and patterns or conditions that are a problem for the safety of patients and quality of patient care. The form also provides legal protection in the event that something untoward happens on that shift and provides some proof that the conditions were or are unsafe. Those hospitals with nurses who are not unionized do not have that ability. And the nurses are left with no voice to protest their assignments and risk to patient safety, and all too often receive no help from hospital executives to provide adequate staffing. As an example, let me just read you a sample. Sorry, got no one. They need to hire more staff. I'll call you back. The patients are coming down. Fill out an unsafe staffing form. Call a rapid response if something happens. The Patient Safety Act is not a government mandate. Question 1 was drafted by nurses who provide direct patient care only after the government and hospital executives refused to take action for 2 decades. It was nurses who collected nearly 150,000 signatures to put Question 1 on the ballot. The limits were developed by nurses who work at the bedside and are based on the best scientific research, established professional standards, and interviews from nurses who work across the state in all types of hospitals. They also took into account the experience with a similar law and specific limits currently in place now for 14 years in California hospitals. The overwhelming weight of academic research continues to demonstrate that patient safety, prevention of medication errors, failure to rescue situations, patient deterioration, patient death, and nurse burnout are all proportionate to the number of nurses staffed in a hospital. Higher staffing levels by experienced registered nurses are associated with lower rates of negative patient outcomes and cost. In fact, studies show that patients in California receive 3.5 more hours of nursing care per day and 5 hours a day more from all hospital unit staff than our patients in Massachusetts. California patients have a lower hospital readmission rate, which decreases hospital costs. Emergency department wait times in Massachusetts are longer than California EDs, and California hospitals score higher on patient outcomes than Massachusetts hospitals. Right now, Massachusetts ranks 48th in the country for emergency department wait times, and emergency department wait times are 47% shorter in California. More nurses with fewer patients result in higher quality care and better flow of patients. We know that now Massachusetts emergency nurses are being assigned up to 7, 8, 9, even 12 patients at one time, and the patients are sick. At a large academic medical center in Massachusetts, after a patient dislodged an arterial line, the patient continued to bleed for a full 30 minutes before the nurse was able to respond to the alarm. In a busy community hospital ER, when her nurse was sent to care for a trauma patient, an elderly woman who arrived for stitches in a laceration on her finger fell when she tried to go to the bathroom. Her call bell went unanswered, and she tried to get up unassisted. She broke her hip, requiring an admission to the hospital, a trip to the operating room, and weeks of rehab. Even the American Nurses Association, an opponent of this bill, supports our position and argues that not only is it safer for patients and nurses, but it is our ethical responsibility. In a 2016 essay for the ANA, the author, who served as editor-in-chief of nursing management for 20 years and was referred to as a living legend by the ANA, notes that adequate staffing levels reduce medical and medication errors, decrease patient complications, decrease mortality, improve patient satisfaction, reduce nurse fatigue, decrease nurse burnout, and improve nurse retention and job satisfaction. I anticipate that my opponent will discuss cost as a reason to oppose this initiative. This is an industry with annual revenues of $28 billion a year, $28 billion in Massachusetts alone. Yet this same hospital industry is threatening closures of hospitals, units, and services when Question 1 passes. No hospitals or services closed in California as a result of implementation of that law. And make no mistake, hospital executives are making decisions now. Massachusetts hospitals are already cutting services. Maternity and pediatric units, substance abuse units, infusion units, and countless behavioral health beds across the Commonwealth, despite many units being identified as essential services to the community by the Department of Public Health. Hospital executives decide how to spend their resources now. Some have even promised pay raises to nurses if Question 1 does not pass, and threaten termination or discipline if they support the initiative in any way. In fact, one local chief nurse officer, not Karen, I'm going to give you that.
Thank you.
Fair. Recently admitted to intentionally telling the local community that if Question 1 passes, the neonatal intensive care unit and trauma service would close. then turned around to the neonatal ICU staff who were resigning in record numbers and admitted to intentionally lying to the community for no votes and offering retention bonuses, stating he had no intention of closing that unit. And those are the people who registered nurses are expected to trust to provide the adequate resources to care for patients. A study by Dr. Judith Schindler-Rothschild of Boston College estimates that by shifting just 3% of administrative costs to direct patient care, the cost of providing adequate staff to meet patient needs would be met. 9 hospitals in Massachusetts that have the worst RN staffing account for 1/2 of the estimated cost for additional RNs. Those 9 hospitals had combined profits of $224 million. And there are a number of savings associated with safe limits. Please take a look at this chart. There was no spike in healthcare spending when safe limits were implemented in California. In fact, California healthcare spending is below the national average, while Massachusetts is well above both California and the national average. There are savings to health insurance premiums for both the employer and employee. Employers in California contributed a larger portion as a percentage to the cost of a single healthcare plan premium than Massachusetts employers, but in actual dollars, California employers paid slightly less per employee than Massachusetts employers. Workers in California paid $179 less per year in healthcare premiums than the national average and over $500 less than their Massachusetts counterparts. The total annual premium cost of health insurance for Massachusetts residents is $520 more than the national average and $567 more than the California residents' health insurance premiums. The data for family plans is a little bit different. Employer contributions at the national level and in both Massachusetts and California are similar, but the cost to employers in real dollars is quite different. Employers in California paid nearly $1,274 less in healthcare premiums per employee than employers in Massachusetts. California instituted patient limits in 2004, and according to that Boston College study, limits resulted in lower personnel costs in California compared with Massachusetts, despite the fact that California hospitals have more nurses employed and pay them higher salaries. In addition, patient limits reduce workers' comp. A study out of UC Davis is believed to be the first to evaluate the effect of the law on occupational health and found that specific nurse-to-patient staffing standards in acute care hospitals significantly lowered job-related injuries and illnesses for nurses. Nurse staffing limits reduce workplace injuries for nurses, a 32% reduction in injuries compared to the national average. And I would point out that the reduction could be even greater in Massachusetts, which is one of the highest rates of workplace injuries for nurses. Massachusetts hospital workers have higher rates of musculoskeletal injuries than other states and lost approximately 21,000 days of work due to injuries. It makes sense that with safer limits, nurses have more time and more support to move patients, to employ ergonomic techniques, and that prevent injuries. With better staffing, there are more staff to work with potentially assaultive patients and to de-escalate those patients. Fewer injuries means lower workers' comp costs and less lost work time and the replacement costs that go with it. Let's talk about quality. Opponents to question 1 talk about the better quality of Massachusetts hospitals compared to California based on leapfrog survey results. But what they don't say is that the federal government reports by CMS or the Center for Medicare and Medicaid Services include every hospital, acute care hospital in the country. Leapfrog is a pay-to-play, self-select, independent business that goes into survey hospitals that pay a substantial fee to be surveyed. A great many hospitals do not participate, and there is no information on the opponents' leaflets about the number and types of hospitals that self-select to participate. Out of 341 hospitals in California, 124 did not participate in the Leapfrog survey, and an additional 22 declined to respond to at least one of the 4 survey areas. Out of the 68 hospitals here in Massachusetts, 11 did not participate at all in the survey, and 7 declined to respond to at least one of the 4 survey sections. Suboptimal quality comes at a cost. Plenty of peer-reviewed scientific research say that with more nurses, there is lower mortality and morbidity. This is about patient care, but we think this makes smart financial sense in the long term for Massachusetts. CMS, the federal agency that oversees many healthcare programs, does not pay for hospital-acquired injuries, pneumonia, falls, surgical infections, or pressure wounds. Many nurse-mediated solutions. CMS publishes statistics on hospital readmission rates 30 days post-discharge and for which CMS imposes fines. Massachusetts is the 6th worst out of the 50 states in this nation for readmission rate and has the 6th highest federal fines paid. California, in contrast, has the 10th lowest readmission rate in the U.S. And a readmission rate within 30 days for the same condition indicates that something went wrong during your hospitalization. Massachusetts is the 6th worst. 90% of Massachusetts hospitals have been penalized, and our hospitals waste $700 million a year on preventable readmissions. Nationally, in 2013, 17.5% of Medicare beneficiaries were readmitted to the hospital within 30 days following discharge. That cost Medicare $26 billion. The research indicates, however, that proper nurse staffing reduces such readmissions and pays for itself over the long run. Just last week at the Health Policy Cost Trends Analysis meeting, Secretary of Health and Human Services Mary Lou Sutters said, and I quote, "In this great Commonwealth, we should be ashamed of the fact that we have one of the highest readmission rates in the country. It has to change. It is unacceptable." Nurse burnout and turnover is an incredibly expensive reality for hospitals today. Unsafe and stressful working conditions have caused 1 of 5 new nurses to leave the profession completely within 12 months of licensure. In addition, 1 out of 3 leaves within 2 years of starting work. These attrition numbers are often attributed to a general sense of burnout that comes from being overworked and feeling pressured to take on more patients and responsibilities than is safe. The impact on the healthcare industry is enormous. The average cost to replace a nurse is estimated to be about $64,000. And as nurses leave, those nurses left behind are required to take on higher workloads, rotate to undesirable shifts, causing more job dissatisfaction and ultimately higher turnover in an attempt to find better working conditions. Turnover leads to more turnover, and burnout leads to more burnout. Improved staffing will stop this very expensive cycle. The law goes into effect on January 1, but the only thing that must be done by that date is for hospitals to have submitted their plan for implementation to the Health Policy Commission. At the Citizens Initiative review held just last week, a couple of weeks ago, the independent expert from the Department of Public Health confirmed it would take 6 to 18 months to develop regulations before the law fully took effect. Any issue that is decided through a ballot initiative takes time, and this is no different. We have seen this process with the recent cannabis initiative, with the opening of the state's first recreational marijuana dispensaries occurring close to the 2-year anniversary date of the vote in 2016. The claim that hospitals have 37 business days to comply by hiring and orienting thousands of new nurses is simply a scare tactic, absolutely false, and intentionally misleading. We believe that every patient in Massachusetts deserves to receive safe, quality care. It has been impossible to achieve this through decades of negotiation and legislation filed. Bedside nurses who are solely and legally responsible for the safety of their patients and right now have little to no say in their assignments have asked for this initiative to move forward so that they can safely care for their patients. Hospital executives retain sole authority to determine how many patients a nurse may be assigned, and there is no limit on that number. We are an evidence-based profession. The evidence is overwhelming that more nurses are better for patients. When you strip everything else away, this measure gives patients more time with and access to their nurse so that when you or your loved one puts on that call bell, the nurse can appropriately respond when they need to and when they should. Staff nurses in Massachusetts are the most highly educated nursing workforce in the nation, and they have taken this action for you, their patients, so that they can provide the care you deserve. This is a patient safety issue. We ask for your support and a yes vote on November 6th.
Thank you very much, Mary Sue. And now we'll turn it over to Karen for the no side.
Okay. Yes, I'm Karen Moore, the chief nurse at Lawrence General Hospital in Lawrence. And I, too, have been a nurse for over 40 years. And as a nurse executive, you have to be a nurse, and your responsibility is to deploy an effective nursing workforce effectively. So my life and my work and my daily activity is about understanding what is going on with patients, what resource needs are there. I am here today to really ask you for no vote. And I actually like to go after you speak, Mary Sue, because I'm going to have to hit very hard on many of the things that Mary Sue has said. This let me start with the one thing we agree with. Nurse staffing is important. Nurses are important. And beyond that, a rigid ratio, so that's the first point. It's the rigid inflexibility of the ratio that actually creates harm. You can have ratios when you work in manufacturing or on an assembly line, but in the dynamic environment of patient care that is knowledge work and teamwork, rigid ratios actually slow care down and can cause very serious declines, delays, and dilemmas. In healthcare, the declines that rigid ratios will cause are in the number of beds hospitals are able to keep open. This is a fact. At Lawrence General Hospital, we actually have calculated that in order to comply with these ratios, which are at all times, days, evenings, and nights, the same ratios. They're the same ratios for Lawrence General as they are for Massachusetts General, as they are for Nantucket Hospital. They're the same ratios that, well, what I want to say is that they are ratios that actually reflect probably our planning numbers that we use today. When we create a budget plan and staff nurses at an average of 4 patients, but the rigid number of 4 patients now creates a bottleneck. And in order to replace a nurse at every time, every lunch break, every time to transfer a patient somewhere, means another nurse has to come up. So this increases cost and the need for nurses by at least 20% right there. Lawrence General Hospital would need 50 to 70 more nurses to comply with this law that goes into effect in 36 business days after November 6th if it was voted in. Those nurses do not exist. Currently, we have about 14 or 15 vacancies in the hospital, and we've been having trouble recruiting nurses to the night shift, trouble recruiting into some specialty areas. We have, nurses are aging out. We have about 4,500 nurses who retire every year. We graduate around 4,000 nurses every year. So there's already a deficit and a shortage of 1,200 nurses in Massachusetts right now. Half of the nurses, those graduate, by the way, the 3,000, are associate degree or lower graduates. We know that the research says that staffing is important, the total hours of care are important, the education and preparation of the nurse is important, and her experience. Ratios, those are the things that make a difference to all the outcomes that Mary Sue has referred to. Those same studies demonstrate that rigid ratios, however, are not the way to get there because that prevents the nurse and the team from using judgment to match the needs of patients with the capabilities of the nurses and the rest of the team at any given time. It is this rigidity, and make no mistake about it, M&A has tried to walk this back, but I'm so glad that you actually read the ballot question. These are rigid at all times ratios. And they've walked it back by saying, well, you can bring in more. We'll have acuity systems. And we do have acuity systems. In 2014, in one of our many efforts to work with the M&A over the last 20 years, which I've personally been involved in, there was an agreement to create staffing ratios in critical care units. Since 2014, over 10% of critical care beds have been closed, and I'll talk about why that happens in a minute. And furthermore, 4 years implementation, the study that came out this summer by Massachusetts researchers, so that they have made no difference to mortality rates in hospitals. And I know from my own hospitals that this has increased costs very significantly. You know, we staff our ICU at Lawrence General Hospital not only for the patients who are there, but the patients we anticipate may come all the time. So we're always staffed higher than for the patients that are actually there. I want to tell you a story because this illustrates the point about rigidity. We had a patient come into our emergency room one winter night, and he needed a critical care bed. We had had a busy night. I think there had been 2 or 3 other critical care admissions in a short period of time, and our critical care capacity was full. We tried to get this patient, despite the family's pleas to keep him in the community, to another hospital in Boston. There were no beds. To another hospital in eastern Massachusetts, there were no beds. Finally, we found the gentleman a critical care bed in New Hampshire. So he ended up going up to critical care in New Hampshire late at night, and unfortunately he passed away the next morning, late morning. The clincher is, in our ICU that night, there were 3 patients who had been what we call downgraded. They were no longer critical care level. The hospital was full. We did not have the medical surgical beds at that hour to move those patients out. And we had an acuity system that verified those patients were not critical care level and in fact did not need 2-to-1 nursing. The nurses were prevented that night, and I'm sure we didn't even ask the question, from having one of them take 3 of those patients, which freed up the other critical care nurse to have moved that patient upstairs for the ventilatory assistance that he needed. I don't know if it would have made a difference to that gentleman's life, but I found out about this incident a couple of weeks later when the family came to talk to myself and the chief medical officer to say that they would never forgive us for making the last 12 hours of his life about wondering where, when, and if he could get proper care. This will happen all the time with rigid ratios. This will happen in the emergency room. The emergency room has 4 different levels described, depending on the time patients have to wait for care. And if at some point, and this has happened in California, we cannot accept patients into the ED, they will wait outside. They will wait in ambulances. They will wait with EMTs who cannot leave those patients and now must wait outside our ED. Even if they are having a heart attack or have had trauma, they will have to wait until we can say we have the proper care. Now, the way we operate today as an emergency room is teamwork. That is teamwork of physicians and expert nurses and technicians. I will tell you, if a trauma or a priority 1 patient comes into our ED, they are surrounded by a team of people immediately. And not 1-to-1 like the law says, but 3 nurses will go in and stabilize the patients while the other nurses take care of the patients that are in there, and then they will reassign themselves. This is knowledge-driven work. This is critical thinking. This is teamwork. And this is where rigid ratios do not work. ED times in California are horrific. This is a study from 2017. So now, I can't do the math quickly, but we're saying 2004 they were implemented. It's 2017. And this is a study of EMS agencies in California that represented 830,637 ambulance transports to 126 hospitals. It showed that offload times varied markedly by hospital and region, and 3/4 of the hospitals detained EMS crews for more than 1 hour. 40% detained them for more than 2 hours, and 1/3 delayed EMS return to service by more than 3 hours. You know, I am speaking as a nurse and on behalf of many, many nurses, including M&A nurses, who oppose this ballot question. There are 7 major nursing organizations in Massachusetts who have gone on records to oppose this question, as well as 80 physician and healthcare organizations. And why? Because we are very frightened of how it is going to transform care, transform access to care. And my last D, I talked about declines in bed, delays in care, are the dilemmas. I am a nurse, and I have to make a decision about breaking that law. Now, the M&A says that's a choice you will make. The fines won't be so bad. But that is not true. As hospital leaders, we are accountable to laws, and we won't break them. We're accountable to regulators, and we are accountable to patients, as is demonstrated in the impact we have to pay for performance. Have you heard about that? If we have infections, you don't pay. If we, have falls, you don't pay. We have penalties for bad outcomes. And the fact is that Massachusetts hospitals do outperform, especially California, on almost every meaningful outcome measure. We have much higher levels of nurse staffing already, and this is a chart that I will just show you, is Massachusetts, and there's California, per 1,000 patient days. We have nothing to hide about nurse staffing. It's publicly reported and has been since 2006, another time that we have sat and really tried to work with the MNA on our opposition to this bad idea, but what we can do for nurse staffing. We were the first state in the country to publicly post nursing staffing for every hospital, every shift, every unit, the plan, and then what was actually provided. And we also list all the other team members that were available to those patients. Nursing assistants, respiratory therapists, IV teams, pharmacists, case managers, educators, clinical specialists that help with patient care. And we can be very proud of that. We have a lot of data to mine there. I'm sure there's more improvements that we can do. We are very transparent across the state. But what we see is this is not a statewide issue. And this is a statewide solution for something that isn't a statewide issue. I'm finally going to talk about the costs because they're real. It has been corroborated twice now, and finally by the Health Policy Commission, which I'm sure everybody here is educated about, is the watchdog for health expense in Massachusetts that was implemented with healthcare reform, and actual cost caps have been imposed on Massachusetts hospitals, and we still have the highest staffing levels and the best outcomes in the country. We have been protecting care around the patient. And that's very, very, very important to remember. So now we have a bill that potentially, a ballot question, that would cost $1 billion conservatively by the Health Policy Commission's estimates. That's very easy to figure out when you look at average nurse salaries of $100,000 a year, benefits, training costs, and the amount of more staff we would have. They deserve all of that. That is fine. But the $1 billion, where is that going to come from? The news media has called this a $1 billion experiment. In the Globe article this week, the editorial, and they were very hard on us. They did not come to this decision lightly. They have not endorsed the ballot question one and vote and support a no vote. So I urge you to look at these factors, very rigid, cause harm, do not bring improvements, and they are unfunded and will not affect hospitals equally. At Lawrence General Hospital, we know we would have to spend about $8 million to hire these 50 to 70 additional nurses to take care of the same number of patients we do today. And we have good staffing at Lawrence General Hospital, and we get very good care at Lawrence General Hospital. We are a break-even hospital. You know, there are some hospitals, they really range in how big they are and the revenue they make. We're the only industry that we spend $235 to make $234 million. I'll tell you, that's Lawrence General's story. We barely break even each year. To have an $8 million unfunded mandate hit us with no improvements to care, it does mean that we're going to have to shrink our footprint. And what is now a 189-bed road-based hospital with the 6th busiest emergency department in the state will have to become about a third of that, about 150 beds, 20 to 30 fewer emergency visits every day that we'll be able to see. And this is real. We are busy modeling if this happens, because it's 12 days away, and it would be 36 days to implementation. And again, I'm glad you read the question, because the question says this will be implemented without delay. Nurses are important. This is a bad question. It is poorly written. There is no flexibility in it, and I urge you to vote no. And if you're on the fence about it, this is not something to be on the fence about. The consequences to your community hospitals are going to be serious. The consequences to the state of Massachusetts are going to be serious. So this is, right now, what we have to talk about is making sure that this does not pass and that we have a no vote. There are many other things we can do in this state. We have a big track record of leading in scientific advancements, in quality improvements, and as I said, in nursing. And another thing I agree with you, we have some of the highest educated nurses in the world here in Massachusetts. We have a 68% penetration of baccalaureate prepared nurses. We're well on our way to our 2020 goal of that being the entry level for nursing. We do not want to go back in time. We want to keep going forward with our good accomplishments and be proud of the care that we give in Massachusetts. Thank you.
Thank you very much, Karen. So do we have any questions from the audience?
Can I comment on a couple of things that she said?
You can, but then I'm going to give her some time too. So take 2 minutes. Go ahead and do that, and we'll give you each two more minutes.
So 66% of the nurses in Massachusetts
And
are part-time.
just before we do that,
Sorry.
if you have questions that you want to ask, if you could line up in the center here, and then we'll get to those as soon as they're both done. Go ahead.
66% of Massachusetts nurses work part-time. Many of those nurses have said that if things improve, they wanted to come back to either full-time or more hours. Many of the new graduates out there are being offered positions that are flex or per diem, and so they are not benefited and they are not guaranteed hours. These are nurses. We have 2,300 baccalaureate prepared nurses that graduate every year and about 3,500 nurses in total. So we do have a number of baccalaureate nurses that are graduating, looking for jobs, and actually going out of state to get those jobs because they are not available in Massachusetts. The Health Policy Commission did do a cost analysis, and if you look at it again, they looked at 80,000 nurses, and there's about 25,000 nurses that work in acute care hospitals in Massachusetts. They rated out 80,000 nurses making a 4 to 6% increase in salary, whether they worked at the bedside, whether they were administrators, whatever their setting was where they worked. So that absolutely is included in that 1.3 billion that they came up with, and they agreed. They did not consider turnover costs. They did not consider workers' comp decreases. They did not consider the decrease in healthcare premiums that would be enjoyed by Massachusetts when this passes as well. So there was a lot. That was not a full analysis that was done. They usually do at least a year of analysis before they release their report. We were told about it a week before. This was done very quickly. They used the numbers that were provided by the hospital industry, when in fact at the same time when Beth Israel and Lady were considering their merger, they refused to use the numbers provided by Beth Israel because they wanted an independent group to provide their numbers. Yet they used the hospital industry's quotas. Judy Schindler Rothschild's survey study says that it will cost somewhere between $37 and $43 million, not be $1.3 billion. She actually used the numbers posted on the patient care website at the Hospital Association, the patient link, and those were the numbers she used for what your staffing is posted to be and what the changes would have to be to make it to what the Ballot initiative says.
You know, if I can respond, there will not be enough nurses, and we cannot staff hospitals with all brand new nurses. But on the financial piece, this is, again, it's been called the $1 billion experiment, and Stuart Altman himself said that's a conservative number. That's a very conservative number. And we had very sophisticated economists do these assessments to look at what the cost of this would be. Judith Schindler Rothschild's numbers are just ridiculous. It shows that, and again, in my role, I am an expert in developing staffing plans and models, not as mathematical exercise, but what they actually take to operationalize. And I think that and I know that those numbers were actually developed with really understanding how hospitals will operationalize. So again, the Wall Street Journal, the Boston Globe, Commonwealth Magazine, people that wanted to believe that maybe this was a good thing has said, I'm sorry, proponents, you just haven't made your case that this is worth the risk for Massachusetts at this time and that it will prove any care.
So, does anybody have any questions they want to ask? Step right up to the microphone. Just give us your first name and then go ahead and ask your question.
I'm Julianne. And I just wanted to hear a little bit more. In reading the law, it does indicate that if there's a public health emergency, there would be a relaxation of these standards, which is reassuring. But what I encounter more is a mass casualty event. And I see those happening in our community on a regular basis, triggered by things like large apartment complex fires or multi-vehicle accidents that we have in winter. And I don't see any provisions for that. So how is it that emergency rooms and critical care facilities are going to have enough personnel standing around ready to meet that need when those events happen? We had a large mass casualty event in Lawrence and Andover and our surrounding community recently, and while very few people were transported to the hospital, it took us bringing in resources from multiple communities in order to meet that need, and it took hours for us to get personnel here. How would hospitals have those personnel ready to meet that need at the staffing levels that you're describing?
So I actually, thank you, Julianne, for the question. You're a pre-hospital person?
I'm sorry?
Do you work as a pre-hospital provider?
No.
Okay. So I actually talked to the staff at Lawrence General who work in the emergency department and who were on the night of those gas explosions to see how it was, how things went. Nurses reported that were off duty, that were not on shift, that went there because nurses are going to do what nurses always do and be prepared to take care of patients. It's the same thing that happened during the Boston Marathon bombing. Many nurses showed up at the BI, at BMC, at the Brigham and Women's to take care of those patients that were potential victims of those injuries. And so there were nurses that were sent home. Once the dust settled and the chaos was sorted out, nurses were sent home because there were so many on staff that showed up to be present, to be able to help when they were needed and if they were needed. Hospitals are right now staffing at an absolute minimum, and we are now using our specialty float pools to fill holes in the schedule instead of actually when an acuity, something happens and the acuity of a floor or patient changes, and they can then respond and help with that. When I started in nursing, we had float pools that were actually identified to help out when just such an occasion happened. Now they're being used to fill holes in the schedule because there are literally whole schedules that come out that are posted that have 4 holes. When 6 nurses are supposed to be scheduled, there's 2 on it. And so we're using the float pools for that to just get to basic or just under basic minimum staffing. And so if we actually had adequate staffing and we're at the level we should be at, and we're able to utilize those float pools as they are intended to be used, we'd actually be able to meet that emergency. The other thing is, if a hospital is out of compliance when something like that happens and it is unexpected, there is a process and they are not going to automatically be fined. That fine is not going to be levied until they go through a hearing with the Health Policy Commission, and it may or may not be forwarded to the Attorney General, who can decide if there is a fine, and if there is, it may be up to $25,000. There are no automatic fines that are levied.
So if I could respond?
Sure.
I'm glad you asked that question too. That was a horrific night, and we were so grateful there weren't more casualties. But you're absolutely right. These rigid ratios would not be lifted except for state public health emergency, which has only happened twice in the last 10 years. The bombings weren't, the gas explosions in Lawrence weren't. And you know, of course our nurses are wonderful. Everybody's wonderful and rallies around during those things, during those snowstorms, during events like that happen, which are not that infrequent. But the point is the ratios are in place. That happened at 4:30. Thank God there were only 14 casualties. It could have happened at 2 in the morning, and there could have been 40 casualties. Mm-hmm. There could have been people that were having trouble getting back into the city. We found that. A lot of people couldn't get back to the hospital that had gone home. So, you know, the point is, yes, nurses and people who work in hospitals, doctors will have a strong commitment to their work, but I hear M&A again rolling back what the law actually says. You know, don't worry, in an emergency, nurses would show up. Hope is not a plan. And, well, don't worry, the Attorney General's office, the HPC, they would take their time and evaluate whether you deserve the fine or not. That's not what you're voting. Read the question. The fines are there. There are call lines, websites, oversight groups that would be available. So again, thank you for that question, because I think it's just another flaw in the way it's written.
Does anybody else have a question? Go ahead, come on up.
Hi, my name is Abby Wertz. I'm a staff nurse actually at a local community hospital, and I work in the ER. I actually was at the ER when the gas explosions happened. But my question actually is about daily life in the ER, and it's going to be for you, definitely. I will vote no on this legislation. I think that it's the best thing that could have come from this is the fact that we're talking about it everywhere on Facebook and with your friends, and I have people calling me, and I think it's a great thing that it's come to the forefront. So I thank you both for that. But on a daily basis, I want to know how you can explain that because patient ratios, which I think are important, I definitely do. I work at Lawrence. I think we do a really good job with it. How, as an emergency room, it doesn't slow down the admissions into the hospital and or transfers into other hospitals, and how that doesn't slow down the wait time to be seen. They talk about, you know, the holding the wall is not true in California, but I just don't understand it. I've been an emergency room nurse for 16 years. If you are slowing down the transfers into the hospital and slowing down transfers out of the hospital with critical care patients, how is it that a patient who's coming in who needs to be seen emergently is not going to stay with an EMT, who are very skilled and wonderful people, but they're not the level of care that we can provide them in the emergency room? And one of the things I've said to my friends, some of them are here, that in order to explain it is, I would have to make that decision. I'd have that in my head. Maybe it wouldn't be a $25,000 fine, but I'd be making that decision. And I know if I saw that that would make a difference in this person's life, I would do it. And I'm sorry, Karen, but I would. And so how do you explain?
Have a moral dilemma.
Yeah,
right?
it's a moral, how do you put, well, right, you put this moral dilemma on top of nurses, some of us who've been there for 16, 20, 25 years, some have been there for 2.
Right.
So how do we put that into the yes vote explanation? That's my
Thank you.
question.
So my background is actually emergency as well, and I remain a certified emergency nurse. And I get it. It is really hard. But the other thing is, and we discussed this at the Health Policy Commission when this ICU law was being discussed, hospitals they retrospectively look at the numbers of patients that come to their emergency room, and you know, Monday nights are crazy, Sunday nights are crazy, right? Tuesday mornings between 4 and 6 are probably quieter. There are ebbs and flows with the typical flow of ER patients, and they are somewhat predictable. They are not entirely predictable, but you have a good sense of when you need to staff appropriately. Right now, we're not staffing appropriately. Hospitals are really at the bare minimum of what they need so that when something happens, when there is a crash on 495, then that creates chaos, and nurses have that moral dilemma, so that you actually do have to make those decisions. If you're actually that thinly staffed and you don't have any flexibility to be able to staff those other emergencies that come in, that's where the problem comes. We've been talking about this, Abby, for 20 years. We came to an agreement in 2006, and at that time, the Hospital Association reneged on their agreement that we had with them, and then the Senate did not vote on it. So we did come to an agreement on it, and the Hospital Association decided that's not what they wanted to do, and they weren't going to change it. We have been talking. So yeah, we're talking now, and we're probably talking more publicly than we have in the past, because nurses do what they're always going to do, and we take care of patients first and foremost. But can you tell me that patients in the emergency room should be one of 12 at any time, because that's what's happening in some of the large academic medical centers. 12 patients in the emergency room, and they're sick, Abby. I don't think that's appropriate. I think we need to have more nurses so that those nurses have less patients. The other thing is, when you have less patients upstairs on the floor, length of stay decreases, so that those patients actually get out more quickly, so those beds open up more quickly. And then if you don't have the readmissions, because we have such a high readmission rate, that decompresses your emergency department as well. So then you're not going to have the same number of patients presenting, because hopefully we can prevent some of those readmissions. So it is not going to hopefully be life as it is today, and hopefully in the 6 to 18 months that the Department of Public Health anticipates implementation to be, that's when it will improve fully, and we can actually look back and say, here's where we are today. But I think saying that this is what it's supposed to be on January 2nd and we can't make that happen isn't right to say, so we got to live with where we're at right now, because it's not right. We are not doing our best for patients, and they deserve better.
Can I respond? Thank
Please.
you. You know, I just need to clear this up. We do not minimally staff hospitals. As Mary Sue said, of course, we study staffing. I mean, there's a whole science around it, the stuff we learn from the data that we collect from it. And you know, in the emergency room, we bring in additional nurses in every hour of the day. It reflects years of, and it gets adjusted as we study this, we predict it. It's actually, emergency rooms are more predictable than you would think. So staffing is planned to be the right level of staffing at the right time, not a rigid ratio, once again. And I just think that, in fact, it is sort of, just the word that comes to mind is magical thinking, to think that a rigid ratio is going to create better flow through the hospital, or that these nurses are going to show up and be able to staff. If there's a 1-to-4 ratio on a unit that has 30 beds, and you have 2 available beds, and the ED is, we deal with this all the time. It always say, you know, get the patients upstairs. A nurse may take, so we have an average at Lawrence General, a nurse may take 3 to 5 patients. A nurse may have to take 5 patients for a couple of hours of her shift. Some are going home, but whatever it is, you make an assessment of the nurse's capabilities with the needs of the patients. And that's how we do things. When we lose that flexibility, it is going to, we are predicting that wait times for an admission bed will double. There'll be 30 less of them, by the way, and so they will double, and that our wait times to get into the ED will also double. There's no doubt in my mind. There's no doubt in my mind.
So the Western Journal of Emergency Medicine published an article just earlier this year. Wait times were shorter. Daughter diagnostics was shorter. Daughter discharge was shorter, and left without being seen was fewer. The daughter admission was no different, because we as ER nurses know when a patient needs to be admitted, right? And you can facilitate that. But if you're taking care of 10, 12 patients in the emergency room, can you do it as effectively if you have 4 as if you had 4? You can't. And Karen, we have 2,000 instances where nurses in Massachusetts said, I can't do this, I need help.
That
and
represents less than 2% of all the shifts worked.
That is 2,000 instances where patients were
Right.
put at risk.
And they are, their documentation of it's not a scientific representation. And believe me, if nurses feel things are unsafe, I want 5,000 of those.
Yeah.
I want 10,000 of those. But I think people, I just need to comment on that this is, you know, we have many, many, many safe shifts, and we have some challenging shifts. But I'm going to ask you a question, Abby, and I don't know the answer. When was the last time you took care of 12 patients in the ED?
I work nights in the ED, and I can't say I've taken 12 patients ever.
Yeah.
In Lawrence. So.
Yeah.
I do take certainly more than what the ratio that Mr. Cox explained
Right.
in the new legislation, but definitely not 12 patients.
And do
So
you
we
consistently feel that you can take care of the patients you have assigned?
I think I take excellent care of my patients.
I'm sure you do.
So we
But I do
only
think-
Yeah.
have a few minutes left.
Sorry.
So if there's somebody else who'd like to ask a question, we can take one more. And then we're going to move on, because we have 2 other ballot questions we want to talk about.
I don't actually have a question, I have a comment. I've been a nurse for 28 years. I still love what I do. I feel, and I am voting yes, because I feel like this law is just as much for the nurses as for the patients. I left the floor. I went to critical care, loved critical care, and swore I'd never go back to the floor, because our patients are getting sicker, our patients are getting bigger. You don't feel like you can take care of them the way they need to be taken care of. I've read the data for the no's, I've read the data for the yeses, and speaking from a nursing perspective, we need to take care of people. I know that there's money involved, I know there's egos involved, but what it comes down to is taking care of other human beings and being able to do it well and not feel like I can't pee all shift, or I got a 2-minute lunch, and leaving going, oh my God, I forgot to do this. Oh God, did I do this? Did I get meds? It's just as much for the nurses as it is for the patients. And we need to take care of the caregivers as well.
Thank you very
Thank
much.
you.
So with that, we're going to conclude. I want to thank Mary Sue, and I want to thank Karen for joining us tonight. It's clearly a question of substance, and voters in Massachusetts have a lot to think about before they vote for question 1. So with that, we're going to move on to question 2 and question 3. For the next 2 questions, we were not able to locate a spokesperson for the no position. So we're going to proceed with representatives for the yes positions on question 2 and question 3. We also want to thank the Boston Red Sox for not playing a World Series game tonight. But we are very happy that we are 2 games up. So just 2 more to go. So with that, I'm going to read the summary for question 2 on the ballot, which goes like this. This proposed law would create a Citizens Commission to consider and recommend potential amendments to the United States Constitution to establish that corporations do not have the same constitutional rights as human beings, and that campaign contributions and expenditures may be regulated. Any resident of Massachusetts who is a United States citizen would be able to apply for appointment to the 15-member commission, and members would serve without compensation. The governor, secretary of the Commonwealth, the state attorney general, the speaker of the State House of Representatives, and the president of the state Senate would each appoint 3 members of the commission, and in making those appointments would seek to ensure that the commission reflects a range of geographic, political, and demographic backgrounds. The commission would be required to research and take testimony and then issue a report regarding the impact of political spending in Massachusetts, any limitations on the state's ability to regulate corporations and other entities in light of the Supreme Court decisions that allow corporations to assert certain constitutional rights, recommendations for constitutional amendments, an analysis of constitutional amendments introduced to Congress, and recommendations for advancing proposed amendments to the United States Constitution. The commission would be subject to the state open meeting law and the public records law. The commission's first report would be due December 31st, 2019, and the Secretary of the Commonwealth would be required to deliver the commission's report to the state legislature, the United States Congress, and the President of the United States. The proposed law states that if any of its parts are declared invalid, the other parts would stay in effect, and the proposed law takes effect on January 1st, 2019. So that's the summary of question 2, and with us tonight is Alexandra Chandler, a former Naval Intelligence officer who worked at the Pentagon for 12 years, who's also an attorney, and who was a great candidate for a 3rd District congressional race recently. So I'm going to turn it over to you.
Thank you, thank you. So with that former DOD background, though I should clarify, former analyst, technically not an officer, I was not uniformed military, but enough time in DOD that I saw enough PowerPoint slides for a lifetime, so I haven't brought any here. And it's also, you'll note, and thank you both for summarizing everything, that summary was a lot shorter because this question is a lot less complicated, And you'll note the lack of any opposition in that chair. That's also because the aims of this question are so very popular, crossing party and ideological lines. I'll say for full disclosure that there are some groups that oppose the aims of this resolution in a non-organized fashion, such as the Massachusetts Fiscal Alliance and others. But I hope to make the case, particularly in the absence of anyone in that chair, that you should vote yes on 2 and why. What I'll aim to do is to take us a little bit through how we got here in terms of the situation of money in our political system, briefly. Then a bit about what we aim to do with this beyond what Bill just mentioned. And then a little bit about how in the end goal, in the ultimate resolution of this, how this could be a part in making our system better. Not just in terms of anti-corruption, which is what we often hear about when we talk about Citizens United, money in politics, but how it can make policy outcomes better and advance the aims of equality, both in our political system, who's involved in our political system, and in our country at large. So, first, how did we get here bit? At the founding of this country, the very idea, not even of donating money to political campaigns, but campaigning, period, was almost unseemly. It was something where if you sought office, that you'd pretty much be receiving people to nudge you, urge you into running. And the idea of actually soliciting donations would have just been unheard of, though occasionally there was purchasing whiskey and things like that to get people to the polls. But there was some concern, the founding even then, in terms of, say, the Emoluments Clause, and which has been in the news lately, in terms of the fear of foreign corruption in our system. But over the course of the end of the 18th century into the 19th century, money in politics was something that was at a fairly low level, though the way that money influenced the system was that those with money, those with property, were the only ones that were really allowed to participate fully in the franchise or be in politics. But campaign finance law really started more in the mid-19th century, where you had things like, and I'm amused as I used to work for the Navy, a ban on soliciting political contributions in the Navy Yard or from Navy shipyards generally, because that had become a bit of a problem. So we've been at this in terms of trying to regulate money in politics for literally over 100 years. And there's been a pendulum that's swung here and there as we've gone through times in our history where money has become more of an influence, and we're talking about, say, at the end of the 19th century, and then you get something of a reclamation of the power of the people under, say, the populist age, and then you move towards the Gilded Age and right before the Great Depression. So this is something we've seen back and forth. But it's really moving closer to our current day, where in the wake of some very bad, putting on recovering lawyer hat, to my mind, very bad decisions that the Supreme Court made in Buckley versus Vallejo and Citizens United, which, along with some other jurisprudence, has taken us to a point where money has this place in our political system. And what that has brought us to is a place where corporations have personhood, and not just the ability to appear in a court and argue for rights, but the ability to spend as they do and how they do in our system. But then also that the jurisprudence has gone so far that even the ability to regulate money, period, in our system is so circumscribed, as we saw how these decisions, particularly Citizens United and others more recently, undermined, really gutted almost all of the McCain-Feingold campaign finance effort in the Congress. So what we aim to do is, and this is where this question doesn't go into such great detail, is there's a lot of debate over how to approach this problem. Even when we talk in general agreement that, well, there should be a 28th Amendment to the Constitution to deal with this, there is a divergence of opinion as to how far that should go in terms of an absolutist view to get money out of politics absolutely and completely and find a way to do that versus a more narrow approach. But that's exactly what this commission will look at. This commission, and I won't recite all of the terms of the membership, 15 members, all of that. But its aim will be to hold hearings, to investigate, to research, to do a bit of comparative political analysis, see how other countries even have approached the problem. And the idea will be that in bringing a diversity of background and ideological view even to the process, that we will come at a more durable solution, a durable proposal that will have the greatest chance of actually influencing the national conversation. Because, not to recite Civics 101 here, constitutional amendments are a hard thing to get done. And what this will be is a step, a small step, but an important step on that road. Not to prejudge the outcome, which would come out of the study, but that's in all likelihood would a proposal for a constitutional amendment to get money out of politics to a certain extent. And what I have to say here, continuing on the kind of what we aim to do bit, is that it's not just to have a commission and have a report, and that's it. There's a lot of commissions and reports that occupy fascinating places on the shelves of various legislative bodies. That's not the point. I will say that I'm an intelligence analyst by profession. I did not say write the book on campaign finance. That would be Jeff Clements of American Promise, which is one of the organizations that supports this, wrote the book Corporations, Not People. But as he describes it, and I agree with this, and I'll bring in my perspective as former candidate in a little bit, it's that this aims to establish accountability, because we have a lot of candidates, a lot of people that talk about the importance of getting money out of politics, but then once they get into office, the priority drops. Other issues come up, and we don't see progress. But if you have a standing commission that is there continually advocating for this and issuing follow-on reports, and they're visibly influencing the national conversation, we can hope to see more progress, both from our legislature acting on this, because with the constitutional amendment, we'd have to have something passed in our legislature, and we would have to eventually go to the Congress, get it passed there, all the constitutional requirements. But to make sure this commission is on our legislature, on our congressional delegation, making sure they are seized of the urgency of this, that is key. And that is where Massachusetts has a real opportunity to lead. This has not been done before. Other states, commonwealths, have passed resolutions expressing the sense of their legislatures that money should not rule politics, or that Citizens United should be overturned. But again, they occupy the place of fascinating resolutions of interesting and curious historical value that sit on shelves. That's not what we're aiming to do here. Now, the benefits of this. I've talked about the benefits of the commission and how the commission can hopefully productively influence the conversation on this issue. But let's be bold and allow ourselves to dream a little bit and think about the root of this matter, which is the influence of money in politics. And if we can go down this road to get money out or to limit its influence in politics, what can we achieve? First, there is the anti-corruption aims, and you have to remember that because of the jurisprudence here, Citizens United, there's a lot of discussion about corporate power, influence of corporations in our system, and that is something certainly to be concerned about. But where we are now, it's become so difficult to even regulate individual contributions. And we've seen the proliferation of PACs, super PACs, where it's not even just about corporate power, but any kind of special interest group or a group of individuals that just decide, I want to start a super PAC and make an independent expenditure of, let's say, a few $1 million here and there. So you have a very small number of people that can have an incredible influence on our system. And the higher you go in politics, the greater influence it is. And it doesn't have to be that way. Then we also get to the policy outcomes, where you consider there are so many policies that are overwhelmingly popular for the American people. If you conduct polling, paid family leave for all, gun safety, student loan debt reform, certain environmental regulation, 50, 60, 70, 80, 90% support. None of it gets passed in Congress. Why? There's not really a powerful lobby for, yes, let's have paid family leave. And millennials with $150,000 in student loan debt don't exactly have massive lobbies for them, whereas on the other side of the ledger are very powerful lobbying efforts. So if you want better policy outcomes, particularly in higher politics, you should be behind this question. And then a corollary to that is this. If we continue to have a political system that delivers terrible policy outcomes or no outcomes whatsoever, talk about trying to get people involved in the process, to get them engaged, to get them to run for office, to get them to just even vote. They see a system that does not deliver for them, and it becomes a self-fulfilling prophecy. And this is how we get voter turnout of, in off-year elections, 20%, that sort of thing. So it's another reason to be for this. And then finally, and this is where I will get a little bit to my own experience. I happen to be a former candidate for Congress. I also happen to be a transgender woman. So I can bring some interesting perspectives to this, is when you have the system as it stands now, what does that mean in terms of who can participate in the system as, say, a candidate? And I mean, there's been a lot of ink, both literal and digital, spilled on the fact that, I mean, you can look at Congress, you can look at governor's mansions, you can look at state legislatures. The higher it is, the worse it is, in terms of who runs and who wins offices. And of course, those that are in office tend to be very wealthy, with connections that are also very wealthy, tend to be male, tend to be white. And those that are not in office, not running, tend to be all of not those things. So women, not necessarily wealthy, people of color, those from immigrant backgrounds, etc. And if we want to change that, we have to change this systemically, structurally. Because what I can tell you is running for Congress is actually quite easy at start. You click on a button on the FEC website and you check a few boxes and you're a candidate for Congress. It's remarkably easy. But if you're going to actually talk to people about running for Congress, one of the first things that even the most well-meaning, progressive people that you can imagine will ask you is, can you raise $1 million? Not, why are you running? What are you going to do? What do you hope to achieve? Can you raise $1 million? And even if you optimistically, you do the grim work of having a spreadsheet going back to your kindergarten friends, I think Lindsay might be good for 250. You do that. And you have your ranges and you determine, yeah, if things go right, I can do it. You are still then in a system where you will spend 4 to 6 hours a day only calling people that could conceivably give you $2,700, the legal limit. And that's no way to run a railroad, a political campaign, or a Congress, or any other of our high governing bodies, the governor's mansion, any others. Because what then happens is that distorts your perceptions of what's important. Because what's important to someone who can give you $2,700 or a group that you are soliciting an endorsement of is going to be very different than the person who, like most Americans, will never give to a political campaign at all. And that's another part of my call to you, that this corrupts us. I don't come sitting here as some paragon of moral virtue, because I was in that system. I made my phone calls, I went down my call sheets and my spreadsheets just like everybody else. The freedom, though, that I have is that I am a former candidate. In a sense, I'm the lucky one. I got out. So I can say this to you very clearly, and say this to you that organizations, candidates, those in office, they are trapped because this is realistically how the system does exist at present. You need money to win. And that's where organizations, even as you're a candidate running, week by week, you'll have to issue your little report. And there's never like, how did the last debate go? Or, how many doors did you knock? How much money did you raise? How much money did you raise? How many hours were you on the phone? That's the only question. Not how it should be. So if you want something better that then will enable women, people of color, LGBT people, people of immigrant backgrounds, to actually stand a chance at higher office where it's not just luck, it's not just you get a video that goes viral, not just a certain set of circumstances. If you want structurally to really work towards equality in the political system, then that's another reason you've got to vote for this. So that's the end of my pitch for this. I welcome your questions, and in the questions, I'm happy to, again, being the good recovering lawyer, do my best to argue the other side, but I think in the interest of time, they're not here. I'm going to just stick with my side on this. So thank you very much.
Thank you, Alexandra. Do we have any questions? Linda?
Hi. Hi, Alexandra. The question I have is, how does one, or can, like a lowly person like me, get onto that committee, that council?
For one thing, I object to your characterization of you as lowly. But the question envisions a process where I believe it's within 60 days of enactment or sometime January, February, where there is to be a simple, one-page application. And what will happen is, of the 15 members, 3 are appointed by the governor, 3 by the attorney general, president of the Senate, speaker of the House. And the whole point is to have diversity. I'll say some of the kind of leading organizers, volunteers for this, have talked very explicitly about the fact that they do not want a bunch of career politicians on this.
Right.
They want
That's
a diversity of viewpoint. So
Right.
please do apply.
Okie dokie, thanks.
All right, thank you very much. Thank you. Rosemary, did you have a question?
Hi, that was very good. Thank you so much. I have a much better understanding of the issue. However, the commission, is this an ongoing commission that will be there, like forever? Or is this, is there a limit to the time? And what about the cost of the commission?
Okay. So I'll start at the end. All commission members unpaid, and though the question doesn't cite it explicitly, I mean, the work that the commission does in terms of, say, like calling hearings or researching data, there's nothing specifically talking about costs for this, that, the other thing. But what I'll say is this: the commission's duties being about research and issuing a report and then being without compensation, the cost should be de minimis. And as for the length of time, that is open-ended by design. Because again, if you sunset this commission in this question, then we're wasting our time from the beginning, because it will just be ignored. It needs to be open-ended to provide accountability.
Thank you very much. Thank you very much, Alexander. We appreciate you coming tonight. So now for our final question, question 3, I'm going to read the summary of that question, which will be on the ballot. This law adds gender identity to the list of prohibited grounds for discrimination in places of public accommodation, resort, or amusement. Such grounds also include race, color, religious creed, national origin, sex, disability, and ancestry. A place of public accommodation, resort, or amusement is defined in existing law as any place that is open to and accepts or solicits the patronage of the general public, such as hotels, stores, restaurants, theaters, sports facilities, and hospitals. Gender identity is defined as a person's sincerely held gender-related identity, appearance, or behavior, whether or not it is different from that traditionally associated with the person's physiology or assigned sex at birth. This law prohibits discrimination based on gender identity in a person's admission to or treatment in any place of public accommodation. The law requires any such place that has separate areas for males and females, such as restrooms, to allow access to and full use of those areas consistent with a person's gender identity. The law also prohibits the owner or manager of a place of public accommodation from using advertising or signage that discriminates on the basis of gender identity. This law directs the State Commission Against Discrimination to adopt rules and policies and make recommendations to carry out this law. The law also directs the State Attorney General to issue regulations or guidance on referring for legal action any person who asserts gender identity for an improper purpose. The provisions of this law governing access to places of public accommodation are effective as of October 1st, 2016. The remaining provisions are effective as of July 8th, 2016, which you might ask, wasn't that some time ago? So, and I'm sure that our friend Nicholas Golden, who has a BA in International Relations from Tufts University, was a former Eagle Tribune reporter and lives in Haverhill, is going to tell us about when he speaks to the Yes Perspective.
Absolutely, Attorney Cox, and thank you for gathering us all together this way and making this setting work so well. Appreciate it very much, and thanks to the Democrats for putting this on. So a lot of you will be asking, and Attorney Cox is correct to bring it up, why, if this passed 2 years ago, are we only talking about it now? And what I'm going to do is I'm going to break this down as best I can and talk about what the law is, what it does and does not do, the myths being propagated by the people who are on the no side, whom it benefits, and what some of the circumstances surrounding it nationwide have been, and what the implications of the yes or no are in Massachusetts. So 2 years ago, as you mentioned, the Massachusetts legislature passed into law an expansion of our anti-discrimination statutes to include a law against discrimination based on gender identity, so in public accommodations. And if you're not familiar, a public accommodation is somewhere like a bus, a restaurant, hospitals, as we discussed before. They're places where one could reasonably expect one to be in public. It's different from schools and workplaces, which already had a statute protecting transgender Massachusetts residents on the books before 2016. So it benefits, obviously, protecting the trans men, women, brothers, sisters, mothers, fathers, all these people we know are neighbors who up to that point had faced discrimination if they, say, had gone to a park. They could be discriminated against publicly if they'd gone to a shop or a restaurant or, heaven forbid, a hospital turned away based on their identity. So up until now, we've had no safety issues, but there has been a group that has decided to, with 1% of the registered voters needed to get on the ballot, put a repeal of this law on the ballot in 2018. So they argue that this law that is already on the books, despite the fact that the question is written such that it makes it seem like it's being proposed for the first time, it's been on the books already for 2 years, they argue that it puts women and girls in jeopardy, that the whole notion that men will go after women and girls and that their safety is compromised by this being on our state statutes. And completely honestly, nothing could be further than the truth. There is not an iota of truth to that. This has been on the law, in our laws for 2 years now, and there has been no uptick in safety incidents. There's been no, what they warned about time and again when the legislature passed this and Governor Baker signed it into law. Governor Baker is supporting yes on this initiative still because, as are the Association of Chiefs of Police, and as are groups like Jane Doe that work to protect women from sexual harassment and sexual violence. There have been no increase in safety incidents across the state, and in Boston, where it's been on the books for even longer than statewide in Massachusetts. So there's no evidence to their claims that this is somehow putting women and girls in jeopardy. And this campaign for Yes puts safety, it's paramount to our concerns, because it's unconscionable to suggest that they're putting women and girls in jeopardy. So nothing about this law has also changed the legality of or allowed stalking or harassment or any of these things. None of that is legal. The law provides, as Attorney Cox mentioned, that gender identity must be sincerely held. One cannot one day wake up and say, I'm going to go be transgender today for whatever purpose I may have. It's spurious to suggest that that's possible. The 18 states and more than 200 municipalities across the United States, with Massachusetts being the 19th, have passed laws protecting transgender people from discrimination in public accommodations and seen zero issues because of this law. So who is for Yes? So I spoke about that briefly, but Governor Baker has come out for Yes in support of this. The Massachusetts Association of Chiefs of Police are for Yes on this question to keep these protections because they do not see a safety issue at place. Groups like the Massachusetts Coalition Against Sexual Violence are for Yes, the National Alliance to End Sexual Violence, the National Center for Victims of Crime, the National Coalition Against Domestic Violence, and so many more are for Yes on this question because they do not see a safety concern. Now, obviously, in Massachusetts, we've stood strong for a very long time on the notion that discrimination is not acceptable. It's about protecting our friends and neighbors such that they would do it for us. And so that gives us a sense of, I don't know if you've seen some of the polls, but the polls have been very positive at points on this question, but I would like to offer a story to you. Houston, Texas, they had a mayor who's an openly lesbian woman, proposed this at a city level as an ordinance to protect transgender people from discrimination in public accommodations, which is, as I mentioned, the law now in Massachusetts for 2 years. Over the summer for their election, they were showing polls with 70% yes. They were full steam ahead. It looked like it was going to happen in a city that, though it's in Texas, is very liberal. And then, unfortunately, that's when the ads came. And we're all familiar with the notion that, political advertisements warp the truth. But these ads were the kind of things, as I mentioned before, that the people in Massachusetts who are no on this question are also spuriously suggesting, falsely suggesting, is that men would go after women and girls in bathrooms if this law happened. And unfortunately, because they spammed the airwaves, they spammed the TV, the question ended up losing with only 60% for yes. 40% for yes, forgive me, 40% for yes, having gone from 70 to 40. So we can't be complacent about this by any measure. Our last polls in Massachusetts for yes show 70% for yes, and that's great, but that was before the radio ads started coming out. The radio ads, again, with these completely false, factually inaccurate arguments that women and girls are being put in danger by this being on the books, which has not been proven true for 2 years of this being in our state statutes. We are one of 19 states that has this on the books, and we know that Massachusetts, as I just referenced, is a very liberal state. The whole nation is watching. The opponents to civil rights for transgender individuals in America have decided to make Massachusetts the battleground for this issue. They believe, and I wouldn't disagree, I don't know if any of you would disagree, that if they can tear down civil rights in Massachusetts, they can do it pretty much anywhere else. We cannot, for our own reputation as a progressive state, be that very true or whatever, and also for what it would mean nationally, allow this to fail. And I will also add, Attorney Cox very kindly read the whole question, but there is some confusion out there about, yes is to keep it. You'd think it would be, yes is to keep this. Yes is to keep this on the ballot. And they've purposely written the question as to confuse as many people as possible. Again, because the tactics are just meeting the lack of fact. If this is to vote no, Massachusetts would be the first state in America to have democratically expanded, supported, protected civil rights for a protected class of our friends and neighbors whose goal is to live life as simply and as normally as the rest of us, but protected from discrimination based just on their identity, on who they are. If we, having democratically passed this, then democratically tear it back, what precedent does that set? I'm skeptical of fallacies that suggest a slippery slope, but it's important to recognize that once we've set a precedent where we can vote to tear people's rights away from them and put them in jeopardy, that is a threshold that even in the state of the United States we're in right now, I would be terrified to pass. There's so much more here to discuss. Even before this was passed, 65% there's this one survey showed that 65% of transgender people in Massachusetts had experienced some form of discrimination. There was a need for this, and that's why we passed it. Gyms with policies protecting transgender people from discrimination report no problems, including Planet Fitness, which we're very familiar here in Massachusetts. There's 50 plus of them. There's a litany of other groups that are in support of this. But my final note to you on this is, speaking personally, the national politics we've experienced over the last 2 years have at times been so despairing. It has felt hard for one to feel like they have any sense of control or ability to stop this. This question that we're facing on the ballot has a direct impact on the safety of countless people in Massachusetts. And we, as Massachusetts voters, have an ability to vote yes and stop some of the heinous activity that we're seeing nationwide, to really make an impact and have, I personally have been more engaged with this than any other issue because I feel a sense that I can stop some of these awful things that are going on. So I would ask that all of you here, if you feel you agree with yes, and I hope you do, that you would consider volunteering and canvassing. That would be great. And also let your friends and neighbors know, because like with the nurses question, like with question 2, there's been a healthy and actually really wonderful to see level of engagement about our ballot questions this year. But when 3 comes up, don't hesitate to let them know that the things that the no group are saying are going to take rights away from people by plebiscite based on completely factually inaccurate statements that spread hate and fear and have no place in Massachusetts. So I'm happy to take any questions. I apologize that it was shorter than I maybe thought or intended, but perhaps we'll all get home sooner than we thought. So thank you very much.
Thank you. Do we have any questions? And we do, if you could just tell us your first name.
My name is Gina. Recently, in the past week, I read that our dear president, excuse me, choked on that, is trying to draft something that would make people's identity be based on sex at birth and not be changeable. Mm-hmm. Do you think that him coming out with this is going to have any effect on our ballot question?
So speaking as I'm not a lawyer, and I also am not completely familiar with where this has been promulgated from. That being said, I work at the legislature, so I'll offer a little bit of that experience. It is something we should be concerned about. Absolutely, it's terrifying. It's horrible. I don't think it will come into effect soon enough to contradict what we're trying to achieve here by keeping this on the ballot. I think the primary goal, and I think we will address that, we should address that as Americans, is to vote yes on this question, on question 3. And that may come into effect later, but I would hope our Attorney General would then step in and try to get some kind of injunction. So at the same time, I'll be honest with you, I'm not a lawyer, I've not seen an analysis of that, so that is just my speculation and analysis, speaking from an experience that I have. Forgive that it's not as informed as it could be, but that's my sense personally, is that the immediate concern is getting out there and letting everybody know that people's civil rights are on the ballot, and it's important to vote yes to keep those civil rights enshrined. So, yeah.
Hi, my name is Sandra, and I have a comment.
Yeah.
I know the group that got this on the ballot with the signatures.
Yeah.
There were a number of religious organizations. And I just wanted people here to know that there's going to be a paid ad in the Andover Townsman coming up this week. I don't know if it's today or tomorrow, but there are over 14 religious leaders, clergy, in the Merrimack Valley who have come out in support of this ballot question. And I think it's important for people to talk to people of many faiths. This is a group of clergy people from all different religions who support this ballot question, and I think that's important because the group that got it on is claiming some religious right to discriminate.
Thank you. And then you mean support as in yes, those groups are coming out with that for yes, okay. Yeah, and thank you, and that's great.
Thanks for telling us, that's great.
Having volunteered at the Unitarian Universalist Church in Haverhill previously on this matter, certainly there are religious leaders who see that this is bred from a center of hate and not from love. But I also wanted to take the opportunity to say, again, like we're voting yes. The question is written as confusingly as possible on purpose by opponents to mislead the voters, which on its own, to me, should be disqualifying. But alas, that's the world we live in. But thank you for sharing that. There are numerous religious groups that are also for yes, because they see it as protecting people from hate.
Thank you very much. And with no further questions, that will end tonight's ballot forum. So we appreciate very much those folks who came tonight to represent different positions on these ballots to help educate us so that when we go to vote on November 6th, or if you're going to vote tomorrow, because you can with early voting, and you can vote through the beginning of next week, that you make a wise, informed decision on these very important questions, which in fact, you are the legislature. You are enacting laws that affect everybody in the Commonwealth. So once again, on behalf of the Haverhill Democratic City Committee, thank you very much for coming.